Hello everyone and welcome back to Online J Academy. So in this tutorial, we're going to cover heart failure. We're going to just do a quick review on heart failure. All right, so let's get started. So when you hear the term heart failure, what do you think? Of course, there are a lot of definitions out there, but I'll just give you a long definition and then here I'll just present a short definition, right? So it's defined as a complex clinical syndrome that results from structural or functional impairment of ventricular filling or ejection of blood, which in turn leads to the cardinal clinical symptoms of dyspnea, fatigue, and signs of symptoms, namely edema and rales. So this is a very long definition, and I'm sorry I said ejection of blood. I'm just saying of ejection fraction because it's what we're going to talk about soon. So a simpler definition would say it is a clinical syndrome in which the heart is unable to pump enough blood to meet the metabolic needs of the body. Okay, so it results when the output of the heart is insufficient to supply adequate levels of oxygen to the body. So there's going to be low perfusion, which we're going to talk about, which you're going to understand when we talk about signs and symptoms. Into decreased blood pressure, which will trigger a lot of compensatory mechanisms, which we're going to talk about in the pathophysiology of heart failure. So we have a couple of etiological factors that we may think of, like a lot of them. But what I'm going to focus on is three major etiological factors, or risk factors, I mean. So three major causes of heart failure would be coronary artery disease, hypertension, and diabetes mellitus. Of course, patients typically have multiple risk factors that contribute to the development of heart failure, right? And we have general causes and specific causes. So when we talk about general causes, we have systolic dysfunction. When we talk about systolic dysfunction, we're saying there's reduced ejection fraction. Then when we talk about specific causes, we have division of systolic dysfunction and diastolic dysfunction. So let's start with the general causes or the general risk factors. So we have coronary artery disease, myocardial infarction, arterial hypertension, diabetes mellitus, or we can say diabetic cardiomyopathy, valvular heart disease, renal disease, and infiltrative diseases such as hemochromatosis and amyloidosis. Of course, there's also sarcoidosis later on. Then for specific causes, we can talk about systolic dysfunction, which is reduced ejection fraction, and diastolic dysfunction, which is preserved ejection fraction. So with systolic dysfunction, we have dilated cardiomyopathy. Maybe this is chronic alcohol use, or it may be idiopathic, right? And then we can talk about cardiac arrhythmias, myocarditis, right? On diastolic dysfunction, which is preserved ejection fraction, which we have preserved ejection fraction. We can talk about restrictive cardiomyopathy, hypertrophic cardiomyopathy, pericardial tamponade, and constrictive pericarditis. Of course, we have other risk factors such as obesity, smoking, COPD, use of heavy drugs, and alcohol abuse. So I'm just going to give you a classification, a basic classification of heart failure, which is based on ejection fraction. So we have two main types. The first type is heart failure with reduced ejection fraction, or also known as the HFrEF. So in this case, we have reduced ejection fraction, which is less than 40%, and this could be due to decreased systolic function, which means we have what we call systolic failure. And this is simply like an inability of the ventricles to empty normally, right? Maybe due to weakening of the myocardium, right? Which will result in pumping dysfunction, which will result in decrease in contractility. Then we have that kind of heart failure, right? Then we have reduced cardiac output. So some of the etiological factors that you might want to think of is coronary artery disease in 60 to 75% of cases, especially in industrialized countries. Then we have myocardial infarction, myocardial ischemia, and we also have chronic pressure overload, like hypertension in 75% of patients, including those patients with coronary artery disease and those patients with obstructive valvular disease as well. So the second type we're going to talk about of heart failure is heart failure with preserved ejection fraction. So before I go to this, when you say heart failure with reduced ejection fraction, we're talking about systolic heart failure or left-sided heart failure. That's the other name for it. But when we talk about heart failure with preserved ejection fraction, this is diastolic heart failure or right-sided heart failure. So we're saying the ejection fraction is preserved, is greater than 40 to 50%, which is good. But we do have decreased ventricular filling, which will result in diastolic dysfunction. And this is usually an inability of the ventricle to feel properly. Okay. Now, it can be due to, like we can say, it's stiffening and a loss of adequate relaxation, playing a very major role in the in decreasing in the feeling and in cardiac output as well. So the cardiac output decreases because the heart is stiff. It can pump enough blood out, right? And this might cause a lot of signs and symptoms that are clinical features that are going to talk about. So some of the etiological factors could be pathologic hypertrophy, which could be primary, like hypertrophic cardiomyopathies, or secondary, which is like maybe hypertension, for example. Could be aging. Remember, when it comes to aging, we're saying the incidence increase with age. So we're saying about 10% of individuals who are 60 years, who are 60 years and older, affected mostly. And it's a very lethal condition, highly lethal condition with a 5-year mortality, right? So, older people get affected. That's why I say with aging, right? And restrictive cardiomyopathy is another one, right? Like infiltrative disorders, like amyloidosis, sarcoidosis. Remember, we talked about the other ones. So there's hemochromatosis, which is a storage disease. Okay. All right. So let's give another classification. And this classification was given by the American Heart Association. So we have 4 stages. They divided into 4 stages. And we start from a point where we do not have heart failure to a point where we do have heart failure. So it starts from a point where it's just a risk factor. And if it's not managed well, it can progress to heart failure. So it's divided into 4 stages, stage A to stage D. So let's start with stage A. So with stage A, we're saying the patient is at high risk of developing heart failure. So the patient presents with risk factors. They have risk factors for heart failure. And these risk factors could be, coronary artery disease, CAD, hypertension, diabetes mellitus, obesity, or even those cardiotoxic agents that people take, right? All right. So, but this patient, we do not have symptoms of heart failure yet. So we just have risk factors, but no symptoms, no structural cardiac changes, right? No hypertrophy, no infarct scars, no dilatation. It's just risk factors. And then with stage B, we're saying, okay, we do have structural damage to the heart. We're no longer talking about risk factors only. We have cardiac changes with structural damage to the heart. And yeah, we have structural changes, but we do not have signs or symptoms of heart failure. So when we talk about structural damage to the heart, we're talking about hypertrophy, we're talking about infarct scars, we're talking about dilatation. So this is a normal heart, and this is a heart with hypertrophy, right? So these are structural damage to the heart. Stage C, we have structural damage to the heart, right? We have structural damage to the heart, but we do not have, we also have signs or symptoms of heart failure. So this patient got signs or symptoms of heart failure. What are those? Some of the examples that we have: dyspnea, we have orthopnea, we have tachycardia, right? We have pulmonary edema, right? Due to pulmonary congestion, pulmonary edema, tachycardia, stimulation of the sympathetic nervous system, and then orthopnea, and then we have dyspnea, shortness of breath, right? The stage D was saying this is now the terminal stage of heart failure, right? So the patient have got all the signs and symptoms of heart failure, and there are structural damage to the heart. All right, so let's move on to the clinical features of heart failure. So the clinical features of heart failure can be divided into 3 parts. We have the general features, we have the left-sided heart failure features, and we have the right-sided heart failure features. So let's start with the general features. So we're talking about nocturia, which is defined as someone who wakes up at night to urinate more than or equal to 2 times, right? More than 2 times or equal to 2 times at night, right? And the common diagnosis could be heart failure, right? Or bladder outlet obstruction, or BPH. Okay, so that's what nocturia is. And then you also have fatigue, right? And then the patient is just tired. The patient is just tired. There's tachycardia, right? Due to, like I said before, stimulation of the sympathetic tone or increase in sympathetic tone. We also have S3 gallop and S4 gallop. So on auscultation. So S3 gallop normally indicates rapid ventricular filling. And when you talk about S4 gallop, it normally indicates a ventricular hypertrophy. Okay? Of course, we have other features that we can talk about, like the pulse with alternance, which is a physical finding, And we're talking about alternating strong and weak pulses caused by alterations in cardiac output. Remember, in heart failure, cardiac output reduces and is associated with left ventricular failure and cardiac tamponade, right? We can also have tachycardia, right? Those are some of the symptoms we can talk about. And then this is a hypertrophic heart. Like I said, S4 Gallup indicates ventricular hypertrophy. All right, so now let's talk about left-sided heart failure clinical features, symptoms that occur due to pulmonary congestion. So what do we have here? We have dyspnea, which is shortness of breath. We have orthopnea, and we have to try to define orthopnea very well because you need to understand what it is, right? We're saying orthopnea is a sensation of shortness of breath that occurs upon lying down. It is relieved by sitting up. So we're saying someone, when they have orthopnea, it happens upon lying down. It's relieved by sitting up, right? Or patient will tell you, I use extra pills to get better. It might present with nocturnal cough. So I'm saying it results from redistribution of fluid from the splenic circulation and lower extremities into the central circulation during a recumbency position, and it increase the pulmonary capillary pressure. So this might occur in other patients with abnormal obesity, or those patients with pulmonary diseases whose lung mechanism favors an upright position. So those are other cases where you might see orthopnea. So this is just a lady who is just coughing at night. You can see it's at night, and then it's nocturnal cough. They're coughing nocturnal night. Then we have pulmonary edema. We're saying blood backs up in the lungs, and then it causes pulmonary congestion, and then it causes pulmonary edema, fluid buildup in the lungs, right? And then we also have paroxysmal nocturnal dyspnea. So we're saying it refers to the episodes of severe shortness of breath and coughing that generally occur at night and awaken the patient from sleep. So the patient will wake up normally about 1 to 3 hours after sleep. Cardiac asthma is closely related to this condition. So let's talk about that cardiac asthma now. What it is, how does it happen? So there's increase in pressure, right? There's increase in pressure in the bronchial arteries, and there's airway compression and bronchospasm. So this cardiac asthma, it actually mimics signs and symptoms of asthma, right? So it presents with shortness of breath, wheezing, and coughing. Okay, that's how it presents. Let's move on to physical findings. Right. So on physical findings, we have bilateral basilar rales, which may be audible on auscultation, and this is caused by the buildup of fluid in the alveoli, right? And also have lateral displaced apical heartbeat because the heart is now big. There's cardiomegaly, so obviously the apical beat will be displaced. And also have coolness and pallor of lower extremities, which is in advanced heart failure. So remember, we're saying there's low cardiac output. Low cardiac output means there's low perfusion of the kidneys, low perfusion of the extremities. So now let's talk about the right-sided heart failure features. And here we're talking about the signs and symptoms, or the symptoms of fluid retention and increased central venous pressure, right? So what do we have there? We have peripheral pitting edema, okay, which is a result of fluid transudation due to venous pressure, right? It's due to an increase in venous pressure. So when there's increase in venous pressure, there's what? Fluid transudation. So when you apply pressure to the pretibial area, right, you will see this indentation, this residual indentation right here. And this is a characteristic of pitting edema. It becomes very visible. And okay, the patient has got like pitting edema. The other feature that we have is hepatic venous congestion symptoms. So the patient will present with abdominal pain caused by stretching of the liver capsule, right? And they might also present with jaundice as well, right? And on physical findings, we normally see jugular vein distension, which is a visible swelling of the jugular vein due to an increase in central venous pressure and venous congestion as well. So you can see it right here. That's jugular vein distension. We have another feature called the Kussmaul sign. So this is a sign characterized by distension of jugular veins during inspiration, and this is due to increase in jugular venous pressure, and it's seen in patients with constructive pericarditis or restrictive cardiomyopathy, right ventricular infarction, and tricuspid stenosis. Okay. Then we have another feature here, which is splenomegaly, which may result in cardiac cirrhosis and ascites. Okay. And we have a hepatojugular reflex. So how do you see this reflex? Reflux, sorry, not reflex, reflux. You exert manual pressure over the patient's liver, which will increase right heart volume overload. And now the right heart is unable to pump additional blood. And now we have visible jugular vein distension that persists for several seconds. All right, so this is it for this lesson, guys. See you on the next lesson where we talk about the pathophysiology of the heart. You can see the video that is going to be made right up here. It's going to be very exciting. So we're going to talk about the determinants of heart failure, how it happens, so it will help you understand how drugs work and which drugs we use and why we use them. That's the purpose of pathophysiology of the heart. That's what will help you understand this. So see you on the next lesson, guys. Ciao.